Okay, welcome everybody. Welcome to the second of 3 webinars addressing wellbeing during pregnancy for women with epilepsy. Epilepsy Action Australia are delighted to be able to bring this information to you with thanks from the Queensland Government for their assistance through their Investing in Queensland Women grant programme. My name is Tina Furs. I'm a clinical nurse consultant from Epilepsy Action, and I'm here today with my colleague Lauren, who will also be available to answer any questions. A recording from this webinar will be emailed to you in the next day or two in case you would like to revisit any of the information. The transcript will also be available on request. Within the email, we will also send you any links to any supports or resources that we've mentioned throughout the evening. There'll be time at the end to ask any questions, but feel free to write them in the chat as we go along. We ask that you keep your microphones muted, however, throughout the presentation, but you're welcome to unmute them at the end of the presentation if you would prefer to ask your question at the end. Cecily, would you like to move to the next slide? Lovely. So just to welcome to country, Epilepsy Action Australia acknowledges the traditional custodians of the lands upon which we meet, and we pay respect to the elders past, present and emerging. Now I would love to introduce Associate Professor Cecily Lander. Cecily is a neurologist and epileptologist. She obtained her medical degree with first-class honours at the University of Queensland, trained at Royal Brisbane Hospital, the Austin Hospital, Melbourne and University College Hospital, London. Commencing work as a visiting neurologist at Royal Brisbane Hospital in 1979, she established an antenatal clinic for women with epilepsy, which continues to serve patients. She is a principal investigator of the Australian Pregnancy Register for women on anti-epileptic medications, established in 1999. She initiated the epilepsy surgery programme at Royal Brisbane Women's Hospital. Cecily served for many years on Australian Department of Health committees for the safety of prescription medications and was Vice President of the Epilepsy Society of Australia. She instigated the formation of the Myasthenia Gravis Association in Queensland and remains their patron and honorary life member. While her current practice involves all aspects of epilepsy management, she has a particular interest in the management of epilepsy in reproductive women. Dr. Cecily Lander was awarded a Member of the Order of Australia for her significant service to neurological medicine and also to the Anglican Church of Australia. Welcome, Cecily. We're privileged to have you present for us today. I'll hand over to you now.
Thank you very much, Tina, and I hope you can hear me well.
Yes, perfectly. Thank you.
Perfect. And welcome to everybody. And it is quite funny, isn't it, to be speaking to a screen? And I was thinking when you were giving that bio that I began in the years before computers were even thought of, even mobile phones, of course. But there you are. That's another story. So very much warm welcome. And I'm still learning to drive this. So here we go. So as Tina mentioned, we are on the second of 3 webinars. The first one is available to you if you haven't heard it, and it's pre-pregnancy. And the third one will be in about another month with Dr. Chris Randall on mental health, resilience and parenting with epilepsy. But let's get to tonight's information. Now, I do want to stress this, and I know we're all used to hearing these sort of things, but every woman with epilepsy in her pregnancy is unique and has particular circumstances. So the comments and discussions in this webinar are general in nature. So it's for general education and information. It may contain content that may not be pertinent or appropriate for any particular individual's circumstances. And for that individualised medical advice and management, that you must discuss with your own professional health advisory team. We're happy to answer questions, but as I mentioned, we can't cover every single eventuality. So I'm going to just first of all set the parameters of what we're talking about. And I'm in particular talking about pregnancy. And when we refer to first trimester, that's 0 to 12 weeks of pregnancy. The second trimester is 13 to 28 weeks. The third trimester is 29 to 40 or term delivery. weeks of pregnancy, and then labour and delivery, and postpartum normally includes 6 to 8 weeks, basically until normal periods return and things coming back to normal. So that's kind of the time frames which we're talking about. Look, there are a lot of, still in 2025, there's still some inaccurate views. Views like this: it's unwise or irresponsible to become pregnant because of seizures or because of the anti-seizure medication. That's not true. You may need to reduce or cease your anti-seizure medication when pregnancy is confirmed to protect the baby. That's not usually true. There's a high risk of having a seizure during delivery. That's not usually true. Pregnant women with epilepsy need to be delivered by caesarean section. That's not usually true. You cannot breastfeed if you're taking anti-seizure medications, and that's not true either. And that's what I'll be trying to unpack in this talk. And overriding all of that, I want to say, and we're so blessed in this country to have usually very good services and good antenatal care, but the great majority of women with epilepsy have uneventful pregnancies and give birth to healthy children. And it's important to keep that in the background. Having said that, all pregnancies need good antenatal care. It's not so long ago that women died in childbirth. In fact, my own grandmother died in pregnancy. So it's only 2 generations back when that care and that comprehension was lacking. She didn't have epilepsy. She died from renal, probably hypertension and renal disease, but she was very young in her second pregnancy. So the prepartum planning, the seizures being controlled as much as possible, having the appropriate medication advice, the safe delivery, and the safe postpartum care for mother and her baby are all imperative. They're all very important in our pregnant mothers. Now, I'm going to unpack a few abbreviations, which I will fall into at various times. WWE, if I put that in, is women with epilepsy. ASMs is anti-seizure medications, and if you're older, you might have heard us talking about AEDs, anti-epileptic medications. We've moved on because what the drugs do is try to prevent seizures. Then the drugs are not curative of epilepsy, they stop the seizures happening. APR, Australian Pregnancy Register. RX, shorthand for treatment. SZ, shorthand for seizures. MFMs, major fetal malformations, abnormalities of the baby's structure, in other words. PK, and I don't think I've used that much, but pharmacokinetics. And it's a really important concept because I do have to talk a little bit about the way anti-seizure medications are handled in the body, how they are broken down, how they are excreted, how we get rid of them. And so the word clearance means how long it takes for the body to get rid of any drug. And the body's amazingly clever. It excretes it either in the urine or in the feces or occasionally other ways like breathing it out, but most often in the urine or the feces. And when I refer to trough levels, and this is true across the board, if your doctor ever asks you to get trough levels of your anti-seizure medication, they normally will mean to get it first thing in the morning before you take your medications. So that's an important concept to get to. You take it at night, the night before, but not in the morning till you've had your blood test. Then you take your morning medication straight after the blood test. And that way, it's the same every time you do it, and you can compare the same state with each blood test. Now, we have lots of wonderful resources, and these are available to you. You've got the link down the bottom here for these excellent resources, Epilepsy and Pregnancy, and this shows you where to find it. And if you look on the epilepsy line, you will see down here Epilepsy and Pregnancy, all these other good sites too, but Epilepsy and Pregnancy is there. So you will find all these wonderful resources. And I think the next page describes a couple more. The pregnancy checklist all the things to think about before pregnancy, during pregnancy, and then over the page after pregnancy. So really useful documents that I would commend to you. Now, occasionally you will see slides that if you've listened to the last webinar, you will have seen before, because Dr. Lata used this slide and I thought it was a good one, and I thought we would be consistent and keep the same pattern. On this side, we want mother to be healthy. We want mother to be free from seizures, because the seizures, all the problems that happen in pregnancy, really stem from that risk. If mother's not having seizures, then she'll pretty much go through a normal pregnancy like every other woman, with the normal obstetric things, of course, but epilepsy won't be a problem. If seizures are happening, that's going to complicate things. Over on this side of the balance that we're trying to juggle, we've got baby. And we've got the major risk of all the congenital abnormalities, the structural changes, things like cleft lip and palate, heart holes in the heart, urological abnormalities like a hole in the base of the penis or something like that in boys, various structural abnormalities. Then there's the neurodevelopmental outcomes, how the baby can talk, speak, think, all those things. And so these risks can happen from the drugs and from the seizures, and that's the risk to the child, both the seizures and sometimes the medications. So we're trying to keep a balance of all these things all at once. And so we're really looking after two human beings right from conception. And that's important to think about. Okay, so on the left side of your screen, you've got the major fetal malformations. These are the structural abnormalities. As I said, hole in the heart, funny orthopedic things, missing bones, missing digits. So it can be orthopedic. It can affect any system. But the common ones would be heart, facial, bony, urological, the kidneys and the genital development, particularly in boys, all those things. And those structural abnormalities, of course, are easy to see, because if they're major, the baby is born and you can often see them. Sometimes they're not picked up till a year or two later, when the baby might have a heart test. And sometimes, of course, they can go through even for many years before a hole in the heart is picked up. And of course, all these risks happen in normal pregnancies as well. It's not just women with epilepsy who are subject to this, but there is a higher incidence and we look harder for it. Now, the main risk of structural abnormalities is in that first trimester, the first 12 weeks. And almost all the drugs we use, both for epilepsy and other things, almost all of them have what we call a dose-dependent toxicity. The lower the dose, the less the risk. The higher the dose, the higher the risk. And that's also true for sodium valproate, which is the one we all know, Epilim, which is a big risk in pregnancy. But even it, in very low dose, has a borderline acceptable risk, and occasionally we have to take that. But in high dose, its risk is catastrophically high. But all drugs affect us more with the higher dose we take. Now, that's the structural abnormalities. On the other side is how the baby develops with an intellect, speech, social interaction, learning. And this risk, the baby may be exposed to this risk throughout the whole pregnancy. The risks may be dose dependent if they are going to be increased by drugs. But of course, you will recognise that many of the risks in this group are innate to the whole community. And we know, for example, children or families who have autism, there's about 1,000 genes associated with autism. So drugs such as anti-seizure medications are one factor, but it's not the only factor. There are many other factors. But we're focusing tonight on the risk of epilepsy drugs, but it is only one risk among many. What do we know? Well, the answer is we don't know enough. We still don't know enough, but we know a lot more. And 25 years ago, when we started the pregnancy register, we knew almost nothing. What we do know is thanks to the large pregnancy registers around the world. And I have to say, the Australian Pregnancy Register stands with a very tall, proud head on this subject, because we've been really much at the forefront of publishing and publicising the results. And the things we've publicised have generally been confirmed by other registers. There's now big whole country databanks, and these are offering a different but also very valuable input, so that you can look at drugs across a whole population, and that is going to give us lots more stories in time to come. But what we know is thanks to pregnancy registers. Now, the whole population has a risk of structural abnormalities, 2.4 to 2.9%. So that's if everyone in the whole world, across the board, has a 2 to 3% risk of a structural abnormality without any drugs necessarily being involved. And so the causes may be viral, may be genetic, there may be lots and lots and lots of things, other environmental factors. So then we've got to look at people on specifically on anti-seizure medication with that in mind, with that background. And so if we merge what we know from the pregnancy registers at this stage, you'll see the three drugs we like using most: levetiracetam, which is Keppra, lamotrigine, and there's lots of generic forms now of lamotrigine, Lamictal, I suppose, was the first one, and oxcarbazepine, which is Trileptal. They all run about a 3.1 to 3.5% risk, which, as you see, is only just minimally above the general background percentage. So these are the three we prefer. From there, they go up, and the highest would be valproate. And I've written here 9.7%, but that again depends on the dose. And on very low dose valproate, it will be less than this. It's probably more like 4, 5, 6%. So on very low dose, it's considerably lower. But then we start asking about combinations, and people are often on 2 drugs or 3 drugs. And the risk of specific combinations is not known. You will find, if you look at pregnancy registers today, that we are commonly combining these 3, because that seems to be the best bet. What we don't know is, are there interactions in between them? So far, there's no red flags, but you'll often find that we're on one or two of those, because that seems to be the safest option. But some people are well controlled on carbamazepine Tegretol, and I spent my life looking after patients on Tegretol, and the great majority of babies were totally normal. I spent a lot of my life with people on Dilantin, phenytoin, and most of the babies were normal. Topiramate has been shown to be a higher risk, and so we try to avoid it, but it's very much dose dependent. And so low dose topiramate is probably not much different to these, but high dose we try to avoid. So having said that, this is where I'm starting to say, for your specific needs, speak to your doctor. But if someone's well controlled, it's very hard to change them, and we've got to have a very good reason why we should, because if we lose control of epilepsy, that is a real problem. I've put here a whole list of drugs about which we know almost nothing. There's a couple of alerts on zonisamide and failure to put on enough for the baby to put on enough weight. They're small for babies. That also happens with topiramate. May happen with acetazolamide, because they've got some similarities in how they work. But there's really not enough to call it. Lacosamide is a fairly new one. You might know it as Vimpat. And while I'm on Vimpat, I'm just going to make this reminder. When I come to the pregnancy register a little bit later, the Australian Pregnancy Register and Epilepsy Action are involved. We are doing a study on drug levels in lacosamide. So if anyone has anyone on lacosamide or knows of someone on it, and you'd like to join in that clinical trial, we would love to recruit you if you're willing, because and I'll explain a little bit more later, we don't know enough about how it works in pregnancy. So far, it's looking very positive in pregnancy. So there's no red flags. No red flags, though, doesn't mean there's no risk. It just means we don't have enough data. Perampanel, the same. We don't have red flags. It looks okay so far. Brivaracetam, which is very closely related to levetiracetam, Keppra. No red flags yet. Tiagabine, very little known on that one. Cannabidiol, just a cannabis, obviously cannabis drug. We don't have enough information on that, but there are some red flags, definite red flags for marijuana, particularly THC, the active drug in marijuana, which is the one that gives you the high. Cannabidiol, as you know, does not do that. So we're hoping that one's okay in pregnancy, but very little information. So, and even an old drug like ethosuximide, we don't have much information on that. I've had many pregnancies with women taking ethosuximide, and I'm not aware of red flags, but we don't have enough data to call it. Okay. What about neurodevelopment? Now, remember I said neurodevelopment is about speech and language and cognition and autism in the baby. And as I mentioned, autism and some of the neurodevelopmental outcomes are also governed by the genetic history of that baby from both mum and dad. So genetics come in here a great deal, and I think there's a lot more to be learnt about people's individual genetic risk when they take specific drugs. And there's some research starting to happen in that space. But what we know right now is that women taking valproate will have children 2 to 4 times increased risk of autism, 2 to 5 times increased risk of intellectual disability and poor adaptive functioning. And we do know that in the old days, and I'm going back 20 years, we had women on high dose valproate, relatively speaking, and I'm talking, we used to be up to 2 grams a day. Now, in pregnancy, if ever anyone's on it, and they almost never are, but at very low dose. So even 200 twice a day would be considered a reasonably high dose in pregnancy. So we try to have no one on valproate, but sometimes we have to. So increased risk, topiramate, growing evidence of increased risk of autism spectrum disorder and increased risk of intellectual disability and maybe some speech problems. So growing evidence, and I think small for date growth estimates as well. So failure to grow as big as the baby should at certain dates. Having said that, the Australian Pregnancy Register, some specific research, and this has only come out very recently, has been looking at effects of other drugs, and even levetiracetam may be linked to a small increase in attention deficit hyperactivity and anxiety. Now, you will understand that this requires an incredible depth of study of children who've been on these drugs and who are then followed over many years. And so to do this, the Pregnancy Register Databank has been accessed by clinical psychologists who've been able to follow children along up to, I think, 6 years, and they hope to do it for more years to see how this pans out over a lifetime. And it's very hard to tease out everything between genetic links and family circumstances, but there's a little bit of a red flag there. Having said that, I don't think we're going to easily depart from our favoured levetiracetam and lamotrigine, because otherwise they seem relatively safe in pregnancy, but nothing is perfect. And I'm going to diverge there and just give you a funny little anecdote, because there is no such thing as a perfectly no-risk birth. There's never been a no-risk pregnancy ever. And I've had a pretty good life, and I've done reasonably well. But I always laugh and say that I could have been a lot brighter if my mother hadn't had a very complicated breech birth and we almost both died. So, there's always something that might have been better. So I don't want us to get too hung up on this. It's good to note, but sometimes we've just got to accept that life carries risks with it. Carbamazepine, sometimes I have seen some structural abnormalities with carbamazepine, but I'm not sure that we can say anything definitive about whether it causes long-term neurodevelopmental outcomes. There's nothing definite that I can say. Lamotrigine at this stage is probably the one that's coming out safest in terms of postnatal development. It doesn't seem to have this little pickup that was picked up by this recent study, neuropsychological study of the Australian Pregnancy Register, following these children up at 6 years and older. Evidence for other medications is completely lacking, so we can't say anything. Okay, let's go back and look at the side from, so that's looking at it from the baby's side, what happens on the baby's development. What about looking at it from the mum's side? What are the risks of seizures? Well, people may have what we call focal seizures, and focal seizures are those often partial seizures in which a person may pause, may be unaware, may not, I call it lights on, no one home, but they may not collapse, there may not be a convulsive movement, there's no hypoxia, but they're switched off. And we know from looking at the EEGs during seizures, the heart rate often goes up very much, and there are some cardiological associates with it. So for the mother, there may be risks of injury. You know, if they're cooking, they may burn themselves, or if they are walking somewhere, they may fall because they didn't see something. And there are increased obstetric risks for mum if the focal seizures occur. For the baby, focal seizures are generally not a huge risk. There may be a small increased risk with respect to electrical impulses affecting the baby and the baby's outcome, and maybe there's a little bit of evidence for that, but it's pretty small. But generally speaking, focal seizures, I think, aren't too much risk to a child, but they certainly are to the parent, to the mother. But generalised tonic-clonic seizures, seizures where there is a drop in oxygen, loss of consciousness, may collapse, may injure themselves, is clearly a major risk, and it is an increased risk of maternal injury, head injuries, all sorts of injuries, injuries to the abdomen in the baby, over here, intrauterine traumatic injury, increased risk of status epilepticus, increased maternal mortality, and it's actually very significant. And if you look at large databases of countries, it is a significant risk of maternal mortality. And there's a 10 times risk of sudden unexplained death in epilepsy. And to my sadness, I've had one personal case where a woman changed from valproate to another drug and she died during pregnancy of SUDEP. So it's rare, but it does happen. And that's why we want to control generalised seizures as much as we can. But the fetal risks are also there. So local injury, traumatic injury to the baby, loss of oxygen supply in very long seizures. There's a documented increased preterm delivery, and there may be some lower IQ if there's many seizures. And one publication suggested that more than 5 generalised seizures during pregnancy may carry the risk of affecting the baby's, again, neurodevelopment, so much as the drugs, one of those other factors. And there is an increased risk of stillbirth. So we always say it's too risky to stop treatment. If someone finds themselves unexpectedly pregnant, seek advice. Don't stop treatment. It's too dangerous. Okay, I'm going to, and this is probably the hardest slide I talk about. It's about the PK changes, the metabolism of the seizure medications. Now, when we take any medication, or any food, it goes into our tummy, it goes into the bloodstream, it gets drained through the liver, and the liver does all this work at harmonising where it wants everything to go and what it wants to do. And in the case of drugs, which the body will see as foreign, it will try and metabolise it. It'll work out what it has to do with this drug and how it's going and how it will eat it up and eventually excrete it. And that's all run by a whole lot of enzymes. But what happens in pregnancy is that process gets ramped up. So you've got mother's liver working overtime, but you've also got baby's liver doing some stuff too. So you've got an increased appetite, if you like, for these drugs. So you take some in, and whereas before you used to get this level, now you're only getting this level. Now, what this graph shows is the clearance, the way in which it's in this case, it's Keppra, levetiracetam. It's how the body is working better. It's increasing the clearance up to, and it starts right in the first trimester, and it stays. And this, it actually, I think, probably goes across over here. I don't know that I quite agree with this, but it's increased anyway. It's 1.5 to 2 times increase. It's working really hard. And so, and each drug may be a little bit different. And this is the sort of thing we're trying to work out for lacosamide, Vimpat, because we don't really know that yet. And we're trying to work that out. So what happens is, if you're not pregnant and your drugs are beautifully controlling and it's at this level, then you get pregnant. If your drug level falls less than 35% of your effective baseline, then seizures may happen. And that's why we've learnt that it's good if we can follow that along and we can increase the dose in pregnancy. So I know it seems counterintuitive and people often don't want to increase the drug in pregnancy, but really you have to, or seizures will happen. And it's well documented now. It's absolutely true for levetiracetam, Keppra, lamotrigine, lamictal, oxcarbazepine, which is trileptal, dilantin, phenytoin. Not true for Tegretol. It doesn't change too much, but I'm pretty certain it does for lacosamide, just looking at my own personal experience, but we haven't got those results yet, but we need it. And I think it's probably going to be true for a lot of others. So we need to look at those and know what ones we have to do. But that's why you will be told, you really need to increase your dose. Okay, so how do we get on with giving women advice? As Dr. Lata would have said, ideally before pregnancy, you get on to the best drug, the best anti-seizure medication for mother, and the best one for baby, if we can do it. So that's going to be one of either levetiracetam, lamotrigine, oxcarbazepine. But some of the others, as I said, are okay because perampanel, brivaracetam, lacosamide, we haven't got any red flags for those. And quite often we have women on those, especially if epilepsy has been hard to control and they're now on 2 drugs and it's working well. We don't upset the apple cart. So we all try to get off valproate, and I try to keep topiramate as low as possible. But for the rest, I won't usually change. Now, we do know that seizure freedom for a year before pregnancy gives us the best chance of having no seizures in pregnancy, and that's well established. And the Australian Pregnancy Register found that first, and since it's had lots of other supportive confirmation. And it's really nice if we can get a drug level, a trough level of that medication at the effective baseline. So before pregnancy, if we've got that, if we say, well, your level is 12 or 10 or whatever it is, we'd like to keep it at that level. So we know what we've got to aim for. And if it gets down to 8, I might say, oh, it's okay. But once it gets to 6, I'll say, this is getting a bit scary. You're 40% down. So we need to go up. You need to go up. And of course, we always recommend folic acid. And I think Dr. Lata talked about that in her talk. My own personal favourite, I always say 1 milligram a day before and during pregnancy. There's no evidence that 5 milligrams works any better, but I'm not worried if someone's on a high dose, but I often say 5 milligrams 3 times a week if you really want to take a big dose, but that is quite a big dose, but at least take some, and that's the important thing. There's no evidence, by the way, that folic acid in our diet in our country stops any structural abnormalities from anti-seizure medications. Yes, it reduces neural tube defects in women who are deficient in folate. That's proved. But as for specifically anti-seizure medication and stopping And does folate stop malformations? No, there's no evidence for that. But we do know good folate in all women who are pregnant is a good thing. And there's lots of other reasons for it as well. Cease alcohol, cigarettes, marijuana of all sorts, and all illicit substances. And I just want to say, remembering again, maternal age, the older you are, the higher the risk. That's always been the case, and it's not different. Even though we girls think we can do everything, independently, an age over 31 starts to increase your pregnancy risk and fetal risk. And assisted fertility treatments independently increase the fetal risk. Now, some people have no choice, but again, you're probably going to be more fertile in your 20s than your 30s. It's just a fact of life. So it's good to remember that. I'm just going to take a quick pause there and see if Tina had any questions or clarifications needed.
No, we're all good, Cecily. No questions have come through so far. Thank you.
Okay.
But a reminder, do start entering your questions in chat if anything comes to mind throughout, so that you don't forget it at the end. And we'll ask Cecily next time she stops for a pause. Thanks, Cecily.
Thank you. Thank you. Yeah, there's a couple of stops and then there will be a big stop at the end. I don't know how I'm going for time, but I better keep going.
4:30. Yeah, well, 25 minutes to go.
Okay, thank you.
Thank you.
Okay, I do chat too much. Early pregnancy tips: maintain a good diet, good exercise, social connections, and well-being. Have a good sleep. Minimise stressors. Gosh, I could be writing out of a textbook, couldn't I? And avoid all those things that we've talked about. Be compliant. Do take your medications properly. Do take your folate. Attend your neurologist early so that a management plan is in place, and join the Australian Pregnancy Register. And I'll be harping on about that a little bit. So when we first see you in the first trimester, if we're lucky, we do try and do a comprehensive history. Pregnancy history, dates, any previous pregnancies and outcomes, and what treatments you might have been on in a previous pregnancy. Medical history, including family history and social circumstance. Epilepsy history, including type of epilepsy, all the medical documentation and investigations. Seizure treatment and control, all other medications, compliance, folic acid, and are there any red flags? And a red flag that I mightn't have mentioned is if you've had a previous pregnancy with a fetal malformation, that's one that I do regard as a red flag, and I look to see, could it be related to the seizure medication? It might have nothing to do with it, but it is sometimes, I think, a red flag to suggest. And I'm thinking of that one in particular. I had one lady who did have a malformation on using carbamazepine, Tegretol, and we thought in her case she should, and I think she moved on to lamotrigine. So it's sometimes just good to, it mightn't have had anything to do with it, but we never can be sure. Remember, it's a collaborative care model, and there's lots of people looking after a pregnant lady. There's the obstetrician, midwife, often an obstetric medicine physician, the paediatrician, as well as the neurologist. And everybody needs to be in on the picture and part of the story. Essential questions: has the seizures been controlled for more than a year prior to pregnancy? Is the current drug appropriate, and is it the optimum dose? The decision about which drug you're on is usually being made by the time we see you. And as I said earlier, we try not to change it. And we absolutely try not to change it if the seizures are well controlled. Occasionally, we would change it. If, for example, someone comes in early pregnancy on a high dose of valproate, we always try to change it. That's another whole story in itself. And it's probably the most difficult scenario we face these days. But we try hard not to have people getting pregnant on high-dose valproate. We try hard not to have any reproductive woman on high-dose valproate. But Dr. Latta would have spoken about that. So are pre-pregnancy levels available that may indicate effectiveness? And then we can plan for trough levels, and then we encourage joining the pregnancy register. And here I'm giving a little bit about the pregnancy register. It doesn't need a doctor to sign you up. You can sign up. just look up the Australian Pregnancy Register for women on anti-epileptic medication. And this is true. Even if you had a baby a year ago, you can actually join in retrospectively. Of course, we prefer it prospectively, that is beforehand, but you can join at any time in pregnancy and up to a year postpartum. And we're really grateful to all the participants. 3,000 women, Australian women have signed up to this, and it's just an amazing database. It has been the best contributor, I think, to Australian women's health. And I'm very grateful to Epilepsy Action for its support. Okay, second trimester is usually fairly plain sailing. I would look at measuring the levels. You might do it roughly, I think of at least maybe 12 weeks or early, 20 weeks, 28, 34, I put in there. But very often just 3 levels, maybe all that are needed if the epilepsy is well controlled and there are no red flags. But if seizures are occurring, that's where we'll do it a lot more. And if the drug levels fall lower than 30% of baseline, you'll be asked to increase the dose. And sometimes just because we know the levels fall, and if someone can't get there or hasn't managed to get a level, I will often increase the dose because I know they will be going down, and we rather do it to stay safe. So very important to do that. One of the other interesting things is if we see a person who's had several previous pregnancies, the pattern will be very much the same, and we know what to look out for, and we know roughly what to expect in the next pregnancy, and there is a certain consistency there. So what about the third trimester? So once you get to about 32 weeks, it's maximum metabolism, so the level probably won't fall after that. You've reached that point, so you're hopefully on a dose that's reasonable. That's where I start to think about, okay, what's the plan now for delivery? And I start to write what I call a peripartum plan for the management team. And this, because often it's in other hospitals, other obstetricians, but I usually think of an extra 1 or 2 days in hospital for mum after delivery so that there's extra seizure management, extra support for the baby. I like to ask for a private room if possible where a partner or someone else can sleep in to allow mum to get some rest. And we like to organise a home support plan for mum, again with partner family, because that's when they need lots of help. And I do like to not have them go home alone. It's much better if they've got a team to work. I also document what I expect will happen with the anti-seizure medication. So sometimes, for example, just supposing the Keppra dose, the levetiracetam, perhaps before pregnancy was 1 gram twice a day, 1,000 milligrams twice a day. In pregnancy, it could be 2 grams twice a day. I've had people up to 7 grams, so that's unusual, but it could be double, so it could be 2 grams twice a day. So postpartum, I will ask them to reduce the dose, but maybe not right back down to 1 gram twice a day. So I might reduce after the first week to 1.5 grams twice a day and hold it there until I'm happy with their progress and know their level. And again, this is where it's an individual recipe. There's no one plan fits all. I just have a red flag for lamotrigine because lamotrigine levels come back to normal more quickly than does Keppra. And so if mum is on a high lamictal dose at the end of pregnancy, say double what she was on or even 1.5 times what she was on, she may get quite high levels immediately or soon after the baby's born. And if she's breastfeeding, the baby can get quite a hefty dose of lamotrigine. So that's one to measure lamotrigine early, and I get lamotrigine dose maybe not quite back to baseline, but pretty quickly within the next week. So again, it's horses for courses. So maybe we'll just keep going through this little pause and we'll just go. So talking about labour and delivery, the place, the method and the timing is the obstetrician's call. It's not the neurologist. I often get asked about it and I say, this is not my call. The obstetrician will do the very best they can for you and your specific needs. But in general, it's true. It's better in larger specialised centres where services are sufficient to support the management of any potential seizures. Maternal epilepsy diagnosis does not of itself necessitate caesarean section. That said, our data does show that caesarean sections are performed more often in women with epilepsy. And of course, as you know, these days, in my day, you had to have a medical reason to have a caesarean section. Nowadays, there's a deal of what the patient wants is also taken into consideration, but it's the obstetrician's call. We don't ever, as neurologists, make that call. I recently had a request for a mother who wanted to do a water birth, and generally speaking, I'd regard that as a contraindication, especially if mum has generalised tonic-clonic seizures. If it's focal seizures under certain circumstances, maybe, but again, it's got to be just the obstetric team who make that. I can only say what sort of seizures they may have, and the obstetrician has to make that call, not my call. And good antenatal care, as I said earlier, is essential. We do know that women with uncontrolled seizures have increased lots of problems: preterm labour, eclampsia, postpartum hemorrhage, and lots of other troubles. So we want it all to be as controlled as well as we can. We do like early pain management. We do stress, we do ask for that, but again, it's the obstetrician's call, but we do know that good pain relief reduces stress, reduces seizure risk. Prolonged labour is not good for anybody, and getting dehydrated is not. But again, the obstetricians take care of that. That's not our area, but it's something just to be conscious of. Every mother gets sleep deprived. It's a really hard one to battle. And all I can do is make sure that the medications are adequate, and where possible, the environmental circumstance for sleep are as good as we can get. Having someone live in a bit longer in hospital, and the medications are maintained through labour. Now, seizures through labour is generally a low risk, and it's probably only 1 or 2%. So it's not many. And if it is, it's treated as anyone else is treated with a seizure, usually with intravenous benzodiazepine. And again, the theatre staff are very good at this. They're accustomed to treating this. And there's a paediatrician available to assess the newborn baby. I've talked already about sleep deprivation, so I won't say that one again. We taper the seizure medication. Sorry there. Are we okay?
Sorry,
taper the seizure.
I'm going to ask a question.
Someone wants to ask a question?
Yes, please.
Yep.
Yeah. When I was giving birth, at the time, I was having a seizure while giving birth, but nobody was fully aware that that was happening. And I couldn't even hold the baby. But the nurses had kept forcing baby to me, yes, to feed, but also I had no muscle in my body to actually. I was totally limp, I guess. So giving birth the whole time was extremely difficult because nobody had known that I was actually seizing, and yet I can understand what's happening. They're telling me to push, but I don't have the capacity the strength, or the endurance to even push the baby out.
Yes, I can imagine that would have been terrifying.
Oh, extremely.
Yeah.
I could hear my heart. I could hear them. Yeah. The nurses going off about my heart rate and stuff. Yeah. But
and they didn't understand what was happening. No.
Exactly. Yeah. I think it's just in wanting to know more, I guess, information about birth and pregnancy. Coming to this year.
Again, I guess I would say that, that was very scary for you. And did you have a neurologist and a pregnancy plan?
I did. Everyone was well aware, but I think everyone sort of went into panic mode more than anything, because I worked in the hospital as well with the people.
Yeah.
Yeah, and
That's an added risk, isn't it? Because if you work in the hospital, everyone thinks you know. Yes, I do agree with
yeah,
that. Yeah,
yeah,
yeah. That is quite a an added risk. Yeah. So
yeah.
I think again, I can't, as I mentioned earlier in the beginning of this, I can't answer specifics because your circumstances are unique, and I'm sorry to hear about that one. But I'm not going to be able to address that other than to say the important thing there is that
Yep.
the staff understand what sort of seizures you have. And maybe what that's saying is that staff need to have a better and I think they don't, I agree, especially if they're focal seizures. People don't understand what a focal seizure looks like. And I think that's a really good point to make, because staff don't, they know what a tonic-clonic seizure looks like, but they don't know what a focal seizure where you're unaware and you're partially switched off, but you're partially switched on. Yes. And they missed it completely. Yeah. So I can that one calls for education of everybody. Yeah.
Yeah. I guess I volunteer my time with Epilepsy Australia as well.
Excellent.
And,
No, well, I think the answer to this is more education. Yeah. I think that is the answer. Thank you. But I better get on or I won't get through.
Yep.
Thank you.
Sure.
Okay. So we taper the dose back for within 7 days for lamotrigine, within 4 weeks for levetiracetam, and look variable for the others. But usually a full-term baby copes well if breastfed, and the paediatrician will check, and I mentioned lamotrigine before, if the baby is toxic on seizure medications. Now, it's very, very rare, but it is important if the baby's premature, and especially if mother's lamotrigine levels are high. And it's usually, the signs are a sleepy baby who won't feed very well. That's the usual sign. But the easy way to check, you don't check the baby's level, you do mum's level. If mum's level's high, you know immediately. So red flags there, but it's usually not a bother and it can be managed quite well if one thinks about it in advance. Okay, so I've done, I think, the postpartum levels. Keep the sleep hygiene at home. That's really tough. If seizures are unstable, have a companion at home. Driving, of course, may be compromised, and if there's any seizures in pregnancy, that can upset the apple cart and stop the driving. Don't forget future contraception, and don't forget newborn care. Don't bathe the baby alone. Don't carry the baby around the house unsupported, but rather get into habits of sitting on the bed, pushing the baby in a pram, anywhere that if a seizure or limpness, as you just mentioned, occur, the baby's safety is not compromised. Okay, because of time, I'm going to push on. So full-time baby, remember, has exposure to a higher level of the drugs in the uterus than in the breast milk. So only a small % gets into breast milk, where when the baby's inside, they get full supply as the blood flows through mum and through baby. So there is a little bit of a preventing of a withdrawal syndrome. So if a mother is on benzodiazepines, are things like midazolam, clobazam, diazepam, all of those, the Valium, that group, that family. If the baby's been exposed to that and suddenly stops, then the baby may get a bit alert or a bit irritable. Doesn't happen often, but occasionally. So breastfeeding takes it down more gently. And even on valproate, breastfeeding is better than not breastfeeding. And there's good evidence for that. So lots of advantages to breastfeeding and really no disadvantages other than sleep deprivation and other than watching for toxicity, particularly lamotrigine. And I've mentioned lamotrigine already. Women with epilepsy are reported to breastfeed for a shorter duration than women without epilepsy. And I'm not sure whether that may be because of the sleep deprivation bit, because it is hard to get enough sleep while you're breastfeeding. It's just one of those things, but it's a good thing to do. In general, though, I don't have any problem with breastfeeding. Being a parent is a big deal, and nothing prepares any of us for it. It takes a lifetime, and having supportive co-workers, people at home, whether it be a partner, a mother, mother-in-law, anybody who can help with companionship, sharing decisions, doing the washing, ensuring sleep, driving assistance, and just turning up. All of those things are so important. Look, more than 90% of pregnancies are straightforward and uncomplicated. And I have to say, the experience of our friend who just asked the question there is fortunately rare, but it does happen. And she was a good example of that. So we do know that. I've mentioned the drugs we prefer, levetiracetam, lamotrigine, oxcarbazepine at the moment. Planning ahead is very important. Folate and taking regular medications and having a trough level is important. So that's kind of the take-home messages. Change the drug if a previous child has had a malformation, has had a developmental diagnosis or autism, but I would also add maybe there's more to the story and look to the genetics as well. Increase the seizure medication as the doses fall in pregnancy. Breastfeeding is recommended, and check the levels postpartum because we want mum to be safe and not having seizures when she's got a newborn baby to look after. And again, please join the pregnancy register because that's where all our data comes from. And finally, it's a great gift, a big responsibility and exhausting work. Enjoy every moment and seek help when necessary. You are not alone, and Epilepsy Action has lots of wonderful supports, brochures, nurses, and lots of people to assist. I want to give a thanks to Epilepsy Action, who do support our pregnancy register, and to my colleague Frank Varda, and I spoke to him today, and he and I set up the pregnancy register now over a quarter of a century ago, and it's been a fund of information. So it's just been remarkable. So I think it's now over to you, and you can all ask all the questions you like. Thank you.
Thank you, Cecily. That was wonderful. I especially like your funny little anecdote. We had a few questions I thought I would pose. One of the questions was around formula feeding. You've been talking, how supportive you are of breastfeeding. Some women can't breastfeed or choose not to breastfeed. In that case, what do you recommend for formula feeding and with toxicity?
This is where I absolutely bow out and go to our obstetric midwives and nurses because I don't know anything. I mean, not since my babies both had formula at various stages. I tried breastfeeding. I wasn't very good, cow, but I tried. And yeah, so I don't know. How do you answer? But I think it's what's best for babies in 2025.
Wonderful.
I don't know whether you've got any answers on that, Tina?
I don't think the choice of formula would be any different for any other nursing mum, really. Yeah, I think the baby's needs are the same, whether the mum's got epilepsy or not.
And it's an interesting question. I wasn't actually inferring that you must breastfeed. I was simply trying to counter the notion that you shouldn't breastfeed. So nothing wrong with formula. And for some people, and the sleep deprivation can be such an issue that sometimes we do recommend, say, yes, you've really got to get your sleep.
Cecily, there was one that I picked out from the list. We asked people for any questions as they were registering. So Lauren and I are just going through those because we haven't had any this evening. So people, please do ask if there's anything else. Many of them you've answered because it was so comprehensive. But one of them we haven't really touched on, I don't think, in there is about epilepsy in children and passing epilepsy down. Where can people get the supports when they're planning pregnancy to find out if they could possibly pass epilepsy on to their newborn child?
Can I immediately, and I can't pull it up exactly, but it's that question is answered exactly on Dr. Lata's previous webinar. I'm sure that I've seen a slide on that, and the risk is under And for generalized epilepsy, look, now I don't want to guess. That's my thing. I'm going to say it's under 10%, but whether I can pull that up, can I
That's
suggest you take
Yeah,
that on notice? But I know it's in Dr. Lata's slides from the previous webinar.
Yeah, we might answer that person
And there is a
specifically and
small
send.
risk of genetic epilepsies being passed. So what is passed on is the gene. It's nothing. It's not the drugs. It's not anything else. What is passed on is a genetic propensity, and we do know genetic propensity for epilepsy is very strong, especially for the generalized epilepsies. It can be also for some of the focal epilepsies, but less so for focal. So, but it's relatively small, and I'm sure it's under 10% for generalized, and I think it's only 1 or 2% for focal, but I'm guessing, and I'd like you to get specific figures from that previous webinar.
We will. I can see Lauren's looking at something there, but if she doesn't come up with it, we'll definitely email that through to the person that registered.
Yes,
So
thank you.
Can I maybe ask a question?
Sure.
So if I've got catamenial epilepsy, so would that be passed? Well, is there a chance that would be passed on to the child?
No. It's not. It depends whether your catamenial epilepsy falls into the focal or the generalized type. And no, there's no specific. I can't tell you any specific incidents. In fact, I can't think of anyone ever. I can't ever remember seeing that occur. So I think the risks are very low.
Okay.
Yeah, I think they're very low. They're certainly not high. They're very low. I can't say it never happens, but it's very low.
Okay. Yep. Yeah. Well, I wasn't diagnosed until I was about 28, I guess.
Yeah. And for people who don't understand the question, catamenial epilepsy means epilepsy occurring at or around the time of the menstrual period. It's hormonally based.
Yeah. Oh, yeah.
Wonderful. Just going back, Dominic, thank you very much, Dominic. Dominic's just posted that there was a study that showed that breastfeeding for more than 4 months reduced the risk of epilepsy. And Dominic's given us the reference for that on the chat. So if anyone wants to look up that reference and read a little bit more, that's amazing. Thank you.
Yeah.
And
I don't want to make people. I don't want to make people feel guilty if they can't or don't breastfeed, because, as I said, particularly my first pregnancy, I was a bit of a failure. So, it just happens. So you don't want to get too fussed about these things.
Okay. I think Dominic was saying any thoughts on this, and it's a question that Dominic gets a lot as a GP IBCLC. So our thoughts on that study. I'm not familiar with that study off the top of my head. I don't know if
I'm not either.
No. Dominic, if you'd like us to have a chat with you about it, if you do ring our 1300 number or send an email in, we can get our research and development nurse to look at that with you and have a bit of a discussion. Oh, sorry, it's Kavita there, but she's writing under her husband's name. So yeah, do email in to make sure we've got your contact details, and I'd definitely love to read that. So we'll have a discussion with you about that one. Shannon also said that, is there a list of obstetricians who specialise in epilepsy, high risk pregnancy in Victoria and Melbourne?
I'm not aware of any in any state. I'm not even aware of that locally. But what tends to happen, that gets sorted out really by the obstetric medicine team. Here, I work at the Royal Brisbane, and I'm not really sure who it does, but I think all the obstetricians take women with pregnancy, but we have obstetric physicians who are on call as well. And so they're always around. So that's why I think it's better in a place where you have more facilities. But as our earlier caller said, even with knowing that the person has epilepsy, sometimes it's still, particularly focal ones, can still go under the radar. And I know from seeing lots of people with epilepsy videos, they're so subtle sometimes. It would be hard as a layperson to pick them up, without seeing the EEG wave. So they can be incredibly subtle and difficult to pick up. So it's a huge amount of learning.
Yeah.
So the answer to the obstetrician, however, is generally speaking, they sort themselves out. And if an obstetrician doesn't feel that they want to deal with complex pregnancies, then I think they sort that out. But I think most of them are very well trained, and they're pretty good.
Yeah, definitely. Before we go on to the next question, can I just flag that we've got the QR code up there on the screen? So that's for our survey, and it really does help us with reporting and seeing how we can improve on these webinars and get some really good content for you. So if people could scan that while we're doing the Q&A, it'll also be in the email with the recording as well. But if you could take a minute to do that as we're doing the questions, that would be amazing. Thank you. Lauren, any more questions you'd like to?
I was just going to say, if anyone has anything sort of individual to them, their specific situation, please feel free to call our 1300 number or send us an email. It's on the slide there, and you can speak to an epilepsy nurse.
Can I ask one more thing? How about do you do neuroendocrinologists?
Hang on, say that again. Is there a thing called a neuroendocrinologist?
Neuroendocrinologist, yes.
No,
so hormone, brain and hormone doctor.
No, there isn't.
No.
Not to my knowledge.
Okay.
No. Not to my knowledge as such, but there are, and I'm trying to think what you're referring to. You're referring, I think, maybe to catamenial epilepsy and the hormones. So the answer to that is there is a lot more work being done on, and it also comes into migraine, of course, because migraine is typically a catamenial. Migraine is absolutely related to periods in many cases. So there is actually quite a lot of research being done, but it is an overlapping area where endocrinologists may see it, but and gynecologists who prescribe pills and things. So it's a little bit of an overlapping area. Dr. Lata Vedlamudi, who spoke last time, she's just commenced, and let me just say, she's commenced a wellness in women, and this is for women over 40, looking at the effects of hormones and hormone changes, particularly in epilepsy, in later life. So that's a very useful study that's happening. And there's, so you can join in. My best answer to that is join in a research group somewhere where you can, and Epilepsy Action or your neurologist may be able to put you in touch with that, where we can add to the growing data banks of people who have all these types of things that we can then study in more detail. Because a lot of it, we have, I have a lot of personal experience, but that's not enough. We need it documented, and we need to be able to analyse it to see what the story really is. And that takes a lot of time and money.
Definitely. I found a group Cecily, on Facebook. That the catamenial type women. There's quite a lot.
Yes, and there's quite a lot of work on that, but still not enough. So
And I have another question from in our Q&A. Victoria is writing from the Philippines, and she's a 31-year-old woman with tonic-clonic absence and myoclonic epilepsy, diagnosed at 5 months old and currently taking Keppra and Lamictal. In the Philippines, they don't have access to specialized neurologists, and only 20 licensed in the entire country, not to mention the fact that neuros and OBs do not want to spearhead the pregnancies, as they want to throw the liability back and forth. In fact, almost all inaccurate views mentioned are still believed here. How do I address this, if ever? Do you have any suggestions?
Hang on, I'm not quite sure of the question. How do you address? What I heard was it was in the Philippines, and there's a great shortage of specialised staff. I think I heard that. Is that right?
Yeah. So I think the overall thing is that they don't want to sort of work with people with women with epilepsy and having pregnancies. They don't want the responsibility in the
Philippines. No.
Yeah.
I can only say that Australians don't realise, I think, most often what amazing resources we have and how lucky we are. And as I alluded to earlier, maternal mortality is one of the yardsticks of a country's health system. Australia's lucky, we are fairly low, but I'm sure the maternal mortality in the Philippines would be a lot higher. So we can only be very grateful. The answer is education, the cost of health, how we address the inequity of that is another whole. It's an enormous subject, and I'm not qualified to comment on, except to say I just have enormous gratitude for our wonderful facilities, and we need to really appreciate those and look after them and do our best to support them.
I have a suggestion that you could contact the epilepsy organisations in the Philippines, in that country, and see if you can support them. They might love to know your personal experience and be able to build on that. And we at Epilepsy Action love hearing people's experiences. It kind of shapes the work that we do because we know what gaps to fill and what resources would be most valuable. So the epilepsy organisations in the Philippines might also find that of use to them. There's also the International Bureau of Epilepsy, International League Against Epilepsy, that are international organisations that's worth hopping on the website and having a look at their different resources as well. So that might be of use and of interest to you. So
I think that's a brilliant answer, and close the gap of the inequity is certainly a big push for the ILAE, the International Epilepsy Association. So absolutely essential. And contacting the local group's a fantastic idea.
Yeah. Should we do one final question that's just come through, Cecily, and then we'll call it an evening?
Okay.
Louise has asked, just wondering about pain relief. Do you recommend a specific type of pain relief over any others? For example, epidural versus gas?
By and large, epidural works better, but again, it's the obstetrician's call. Yep. So I just say, please give the best analgesic that you can do, but I have to leave it to the obstetric care team.
Yeah.
And because they know the circumstance, they know it from their angle, and they're the ones administering it. They're the ones who take responsibility for it. But in general, an epidural works better than gas.
Yeah.
That's all I can say, really.
Brilliant. Great answer.
But it's not my call. I can't call that. So you'd need to ask your gynecologist obstetrician that. But I have to end with one funny quip, because 49 years ago I had my first baby, and I have to tell you, I ordered my epidural with conception. You can pause. So as soon as I was pregnant, I said, I'm wanting an epidural, because it was relatively new in those days. But I'd seen enough babies delivered that I knew how it worked. I ordered my epidural with conception. Yes. So I think I should end on that note.
Brilliant.
And he was 49. He was 49 last week.
Amazing. Thank you so much for that. A bit of humour as well as your in-depth knowledge that you've shared with us this evening, which is great to end on. So again, I'll just prompt people to please use the QR survey and let us know any feedback that would help us to shape these in future. Also, there might have been a couple extra questions, but I think we better let Cecily, she's had a long day. As of our nurses, but Make March Purple, as you can see, still sporting the T-shirt today. We've been out and about all over the place. Please email your questions in to Epilepsy. Our nurses will be really grateful to receive them and really happy to answer them tomorrow. So a huge thank you to Cecily for presenting to us tonight. A big thank you to Queensland Government for the funding that's helped us to put these events on for you, to Lauren and everybody at the Epilepsy Action team, and for everybody for your support and attending. Please do register for the final event on the 30th of April, correct me if I'm wrong, Lauren, which is Dr. Chris Randall, which is what Cecily mentioned earlier about building resilience, looking after your mental health, and some parenting tips. And we have a new mum called Lily, who's going to come along to that one and share her own experience for us as well. So really looking forward to that one. So thank you, everybody. I wish you a good evening. Enjoy your evening. If you're in WA like us, you've got the evening ahead of you. So thank you very much.
Thank you.